It's just after afternoon on the East Coast, so we're glad people are represented from across the country. And as a reminder, this is the Clinical Trials Network, a Translation and Implementation Special Interest Group. So CTN TNI SIG is what we're known as. And we've been meeting now for close to 2 years, believe it or not. And we meet every other month. I think, membership is free, and we're open to anyone and anybody interested in clinical trials and infusing clinical trials work with dissemination and implementation science. So we're very excited to be able to work with many of you, and really just kind of keep the translational thinking throughout the process of any clinical trial. So I think we've got really 2 agenda items. The first is to introduce Dr. Robin Williams, who's really, I think, emerged as the leader in the field around quality measurement, around addiction care cascade, opioid care cascade. And it's really awesome that we're going to be able to hear from Dr. Williams directly. I know we've adopted a lot of his methods in the work we do with safety net clinics across California, and also in the state of Washington, and really a few other places. And it's really fantastic work. And we know that people are on the side of the opioid treatment delivery also are using HEDIS measures and value-based payment systems that really are driven by a lot of Dr. Williams's work. So I'll do a little bit more formal introduction in a second, but we're also going to save some time towards the end to hear from the implementation outcomes work group and the implementation strategies work group. So Sophia and Camille, if you are going to be leaving early, maybe you could give us a ping, but if not, we'll look forward to hearing from you, towards the end of our time today. So I think, why don't I just jump in? We're excited to have Dr. Williams with us. He's an assistant professor in psychiatry in New York. Robin, I'm blanking on the institution you're with.
At Columbia.
No, Columbia. That's a highly regarded institution. I'm sorry to have blanked on that. But really, you have been funded by NIH and NIDA, and is really funded also by CDC, and works within the context of the CTN, also SAMHSA, and really has really paved the way as the expert on the opioid and OUD care cascade. And really remarkable trajectory for still a relatively earlier career person, but I don't think of you as early career at all. I think of you as one of the main figures in our field. So Robin, take it away. And I think we have it so that you can share your slides.
Very good. Thanks so much, Mark. Great to see you all. Lots of friends and colleagues here and familiar names. So this will be a high-level review of a series of studies that I've been lucky to work with a whole array of teams on over the last 5 or 10 years. And I'm going to try to nest them all under the OUD Cascade of Care. And so I'll touch on that framework for people who may be less familiar at the top. I'll also give a heads up. I'm going to attempt to have 2 brief straw polls toward the top of the presentation as well. So if people are able just to enter responses in the chat, I think that'd be helpful, just for a little bit of context. I'm familiar with a lot of you, the work that you've done, and I think several of the studies I'm talking about will dovetail with some of your studies and findings from the last couple of decades. So today, I want to start with a couple questions. So one, especially for clinicians, people who are actively treating or have treated patients with OUD in the past, do you ever have patients ask you when they can stop buprenorphine? Does that ever come up? It's kind of a yes/no question, but feel free to ad lib a bit more. if you'd like. This is the kind of thing that patients are often asking. I once wrote a whole R01 and it was framed around this question of, doc, when can I come off of this? Which eventually got funded, but not, the phrase probably a little too colloquial to the way it was first framed, but it comes up constantly clinically. All right, here's another question. How long is long enough for continuous maintenance treatment with buprenorphine? And you can sort of put that in a number of days, months, years, however you want to phrase it. But what, the patients ask this, families ask, clinicians, colleagues ask about this. I had an article published recently on insurance status and payment source for buprenorphine care episodes. And a very senior person we all know in the field wrote me and said, it's good to see this in terms of how important it is to have in-network benefits, because there are still holdouts at high levels who think it's better for the patients to have to pay to get bupe so they don't stay on it for too long. So they have some friction there. So, I think we all are familiar, RDD will be great to see what comes from that. I think some of what I'll show you on the longer term care episode studies here may potentially complement how we interpret the findings from RDD. Finally, for those of you who've practiced across different treatment settings, do you have different care pathways based on, this is for buprenorphine treatment, based on patient presentation and response to treatment? And really what I have in mind here is formalized, protocolized care pathways, not just sort of patient-centered care or something like that, but really if you think about depression pathways or risk level, things like that. So I just wanted to ask a couple questions to give a bit of framework for what I'll be trying to address here. I think all of these numbers are familiar to people. I'm bringing them up mostly to help anchor what I'm talking about around the cascade in particular. So we know that we have incredibly effective treatments for OUD. You think about the effect size of MOUD, in particular buprenorphine or methadone, and this is on par with a stimulant for ADHD, with a penicillin for group B strep, something like that. The treatments work. The problem is that the great majority of people don't get treatment. Among people who do get treatment for OUD, the majority of care episodes don't initiate a FDA-approved medication, and then among patients initiated medication, most people drop out within a few weeks or months. And so the two critical stages for the cascade really are medication initiation and medication retention, because our population level results for that across the country are really poor. The NQF has come out with 180 days. So this is now a HEDIS measure for continuous treatment. And this 6-month mark is measurable in a given measurement year. So it's a bit more feasible to measure the multi-year period. And also it's poor. So if you look nationwide, it's about 30% of people who successfully stay in care for 180 days continuously. At the same time, this was not an empirically informed measure. This was more of a derived from expert consensus and based on feasibility concerns. Because this is also because the evidence base is lacking, and it's very hard to study multi-year episodes, especially for people who are continuously insured given churn and limitations with available data sources. So just a brief overview of the cascade. So this is a public health framework. Initially, about 2010 or so, this became popularized for use for HIV. And there was a 90-90-90 goal, which was to successfully, screen but diagnose 90% of people who do have HIV in the country, to help 90% of people engage in care services, 90% get on to antiretrovirals, and then have 90% of those individuals virally suppressed. This was mathematically modeled as a way to improve individual health, but also as a way to suppress transmissible levels of HIV in the population to reduce the spread of HIV as well. So that doesn't translate in the same way to OUD. We don't have the sort of the final stage outcome as a biometric, the viral suppression, the way that you could measure viral load in OUD. And so this is something that I tend to try to avoid talking about in terms of the final stage. But I do have a study that's under review right now that speaks a bit to that in terms of here on the right, you can see, do we call this remission? Do we call it recovery? Do we call it continuous opioid abstinence? And I think there are a lot of justification, strong arguments for framing it, naming it in different ways. And there's not as much consensus, which I think in part has informed why I've been more focused on medication initiation. Medication retention are really the two critical things that we need to focus on. So this is more a caveat, a qualifier for the presentation today. We know, especially in recent years, that the overdose rates have increasingly been driven not just by fentanyl, but by co-use of psychostimulants. In part, that's because some people really are primarily psychostimulant users, cocaine or methamphetamine users, maybe benzo users, and then they wind up getting exposed unintentionally to fentanyl in the drug supply. And so the point here is to show, it's a very busy slide, but in this figure, the cascade is on the far right. For people with OUD, the treatment cascade is appropriate, but then in this middle left blue box, there are plenty of people at risk for overdose who don't have OUD, and there are other evidence-based services to which they should be connected, but that stands apart from the cascade itself. So it's the point is just to be clear, the cascade's not trying to do everything for everyone. It's really for people with OUD who are eligible for MOUD. That want to help shepherd people through these sequential stages of the cascade. Prior work unrelated to me, but if you look at commercially insured individuals on a variety of MOUD modalities, this is just to reiterate that 6-month retention is pretty poor. Also true for buprenorphine. If you look at multi-site or national samples, these are the figures that tend to replicate across those. So now I'm going to drill down on a couple studies that we've published looking at predictors of engagement and subsequent outcomes, drug use, also looking at retention, and the 6-month retention mark will come up repeatedly throughout this talk. So the cascade, I mentioned sequential a second ago, really is a framework of sequential progression through these stages. So the idea is that people cannot leapfrog stages. Reality is always a bit messier. Any model, is going to be wrong. Some are more useful. But we actually thought, when we had some data a couple of years ago, we could look at this specifically, whether engagement really was necessary. Mark mentioned HEDIS measures, which are the most widely used measures around addiction treatment in the behavioral health landscape with insurance plans. And HEDIS engagement is defined as once someone has their intake visit for addiction care, do they have at least 2 more services within 34 days of that index visit? So it's basically, do they come back into care at least twice in the next month, more or less? And we had a sample of almost 50,000 patients and almost a decade of data. The great majority were Medicaid beneficiaries. And we were looking at the EHR records for these individuals. And we were assessing whether did engagement status matter? So if you look at the people who did meet HEDIS engagement criteria in the first month, what were their rates of retention compared to people who did not meet engagement? And this was in a treatment setting where patients were intended to come in on a weekly basis, sometimes twice a week, but at least once a week in that first month. And these were new care episodes. So we published this a few years ago in the American Journal of Psychiatry. And it was not a surprise, you can see here, that among people who successfully met engagement criteria, half of them were in care at 6 months, compared to only 2.9% of people who did not meet engagement criteria. And so it wasn't a surprise. What impressed us was the strength of the relationship and this odds ratio of almost 30, showing that for the great majority of patients, if you lose them in that first month of care, they're not going to come back, or at least they're going to have a prolonged period where they're out of care in that given system. So it really emphasizes this first month of care as being a critical window. So this gets back to the care pathway question. When someone presents for care in a given setting for buprenorphine treatment, do we have pathways that identify the high-risk patients, high risk for early dropout? versus those who are more likely to stick around? And how do we identify who those patients are? Who at presentation can we predict who will still be in care at 6 months, just based on their baseline characteristics? So this is a kind of like a table one for the sample of the commensurate sample of people at this buprenorphine, multi-site buprenorphine clinic system in about a dozen states. And these demographics are what you tend to see, slightly more men, tends to cluster in people around, 38 plus or minus 8 years. And then you have a variety of drug use trends, other, infectious disease status, things like that. So this is the second straw poll. What would you say, and I'm prompting with an itemized list here of baseline characteristics, what would you say is the most prognostic of successful long-term retention? So if you can just put something in the chat based on what you think or what you've observed or know from the literature to be most strongly associated with successful retention and care among patients with OUD starting buprenorphine treatment. And part of why I wanted to emphasize this is that, understandably, there's a lot of emphasis currently on demographics, on social determinants of health-related social needs. And if you look across studies, however, so housing status, age, I think if you really do a review of these baseline characteristics and what is associated with care outcomes, it's not as intuitive as you would think. So age, there, you look at 6-month retention, there may be a 5% difference, 10% difference based on age. So older patients tend to stay in care longer. Women tend to stay in care a bit longer than men. Non-Hispanic whites tend to stay in care a bit longer than minorities. But these are not big effects. So the associations are still in this sort of single-digit range. There clearly have been, some of you have done these studies that have shown that patients who come in with methamphetamine use disorder or with alcohol use disorder, comorbid to their OUD, that they have worse outcomes. But for the most part, I would say that it's more mixed and specific to the setting. And it's not a reliable predictor, because sometimes when you run adjusted analyses, those patients are no more at risk for dropout. Yeah, so Kelly's answer is anticipating what I'm going to share. So we ran a study, it's published in JSAT now, maybe 4 or 5 years ago. And we looked at people who came into care already using buprenorphine. And we found a 2x difference in terms of retention throughout the first year of care. So this dwarfs age, sex, race, ethnicity, injection history, HIV status. It's a huge effect size compared to those other things. And of course, one of the first questions everyone understandably asks is, well, how do you know whether these are care transfers? So you have someone who's long-term, stable, and full, sustained remission from OUD, has been on buprenorphine maybe for years, moves, job change, insurance change, enters care, long-term stable on bup. What we showed after manually coding 1,000 charts was that the source of the buprenorphine, whether it was a care transfer or someone, using street Suboxone or non-prescribed bup, so, diverted bup, that didn't matter. Those curves overlapped in red and green. But for the patients who came in, they're not necessarily naive, but came in buprenorphine negative, there was still this twofold difference in terms of retention. And this really is in the charting. It's very straightforward. And this was just example language that we pulled out from the manual coding. And that was also true for rates of opioid use in care. You can see there's about a twofold difference in the likelihood month over month of having an opioid positive urine for people who come in buprenorphine negative at treatment entry. And I think part of this speaks to the kind of the natural history of OUD and motivation. You look at, I mentioned the average age here is 38 plus or minus 8 years. But if you look at overdose mortality in the US, it's much earlier than that. So unfortunately, you have a lot of these younger adults who are dying from overdoses and injuries and things. in their 20s and early 30s. But for people who survive over time, tend to gravitate toward treatment. Fine buprenorphine is more affordable, maybe more accessible on the black market than prescribed, but gravitate towards bupe to try to control their opioid use. Now, it's also interesting here is that if you can keep people in care, and this, is coincident with the 6-month mark, that by about 8 months, if you can keep people in care, the rates of their opioid use converge based on which cohort they were initially in, based on buprenorphine status at intake. But I really think, Kelly, I love that you wrote this in the chat, kind of unprompted, that it's really rare that I hear clinicians or health systems talking about how to stratify patient care pathways based on buprenorphine use at intake. And I think part of the problem too is that patients think they need to test opioid positive. Clinicians often think the DEA requires an opioid positive test. And the patients conceal their buprenorphine use, so they're worried about getting in trouble for using diverted buprenorphine. So everything's kind of twisted around, and I think out of step with some clinical realities, but also the way we could optimize care pathways for patients. So let's look a bit more at longer-term retention. The Cascade model that we've been publishing since about 2016 has had retention at 6 months. This predated the NQF measure, but I think reflects how it is a measurable amount of time and would still be an overall improvement in what we see nationwide. So we had a study with Medicaid. This was market scan data for people who are familiar. So this was the anonymously reporting roughly 8 states. So you would hope that this would more or less generalize to national analyses, but we don't know which 8 states these were, but it's a large number of Medicaid beneficiaries with OUD. And the point here is that we wanted to look at people who were in care for at least 6 months continuously, but then we divided cohorts based on when people did discontinue care. Those who were in care for 6 to 9 months, which wound up being the reference group. And then we looked at people in care for 12 to 15, and 15 to 18 months. 9 to 12, 12 to 15, 15 to 18. And then we looked, the outcome window was post-discontinuation in the insurance claims for these 4 adverse events: ED visits, all-cause hospitalizations, receiving an opioid prescription, medically treated overdose. Of course, we couldn't observe fatalities. People wouldn't have been continuously covered. So these were in the years 2013 to 2017 for adults, excluding dual eligibles for Medicare. A little bit of a complicated setup. So this figure just shows there's a 60-day buprenorphine-free period, and then we constructed these cohorts, and in red, the outcome window over the 6 months post-buprenorphine discontinuation. You can see a consort diagram here. But I'm just going to jump. I'm happy to go back to any of the slides, but just to go to the conclusion here, what we saw was that there was a bit, and my biostatistician says I'm not supposed to say this, a little bit of a dose response relationship where the patients who were in care for longer and longer periods did have statistically significant reductions in their risk of ED visits, for instance, or getting an opioid prescription. If you take a step back, though, it basically looks the same for everyone. We were shocked. So we really thought that this is like cherry picking the patients. If only about 30, 35% of patients are still in care at 6 months. And then you're looking at people in care for even 12, 15, 18 months, you would really think that they look pretty good, even if they discontinue treatment. And what we're showing here is that that's not true at all, that when patients discontinue buprenorphine, even after a year and a half, this is really a high-risk period. 1 in 20 people, 5% of people, had at least one medically treated overdose in the 6 months following their treatment discontinuation. So this gets to, I would suggest these are alarmingly high rates of adverse events that are similar to how we think about the post-release, formerly incarcerated population. And yet our systems of care aren't really designed in a way to reflect that in terms of someone's been in your buprenorphine clinic for 6 months or a year and a half. You think they're doing okay after a year and a half, and then all of a sudden they're not coming in for their appointments, or they say that they have a new job and they're going to taper off their bupe or whatever it is. I don't think we think of it necessarily as a high risk event. So lots of limitations inherent to insurance claims-based analyses for this. Just reiterating the high-level conclusions here. So one question that's embedded in that work was, how do we define discontinuation? This was the study that Helene had just circulated prior to the talk today. And this just came out on May 5th in the Green Journal. And this is a question that reviewers, journal reviewers, grant reviewers often bring up is, well, how are you defining discontinuation? How can you justify that? What's the citation for that? And we're hoping that this will become a widely used citation, because we, under MyK and now in R01, we realized that we had data sources where we had both prescription level data and visit level data, structured data for both of these categories of data. And then we could use varying definitions of what constitutes discontinuation from buprenorphine. So one element of that is usually the allowable gap in coverage. And if you look across studies, that's often anywhere from 7 to 60 days. I would say most of the time it's going to be 7 days, which tracks with what are often standard approaches for pharmacoepidemiological studies in general. But I think that the problem there is that, if someone goes for 7 days without taking an antidepressant, that's very different than if someone has a 7-day gap in their monthly refills of buprenorphine. Because especially for the prescribers on the call, you've probably written for 2 sublingual 8 milligram strips a day. The patient takes 1.5 strips a day. And so a 30-day written prescription is really, a 40-day supply, or however that translates. And so the 7-day window is much too narrow to represent clinical realities, especially for patients who've been in care for more than a few months, or certainly for more than a few years. And yet, this is an empiric question. And so we wanted to go after it. And this is a matrix we put together looking at successful 180-day retention. And you can see on the diagonal, this is just the percent of people that did successfully retain for 180 days. And it was anywhere from 18 to 45%. The more generous window of 60 days clearly allowed for higher, retention rates than a more conservative 7-day gap. And then what gets a little confusing to see here is that above the diagonal, these are the percent agreement using the varying definitions, and below the diagonal, these are kappas. So that's going to adjust for the variation across the results. And we starred, to try to make this a little bit more visually digestible, we starred the highest rate of agreement here, which is based on a prescription gap of 30 days. So if someone, based on their prescription activity, and this isn't based on when they take it, but when they fill their prescriptions, so this would be if someone fills a 30-day supply, they'd have to go for more than 60 days without a refill, so that there's a gap of 30-day supply. And that was the most reliable and consistent definition for discontinuation. And it had high concordance with visit-based gaps of anything from 37 to 60 days. So one of the surprises in this was that if you use a visit-based definition, the results don't really change much, whether you use a 37, 45, 60-day gap. And these are meant to reflect the 7, 14, 30-day gaps of prescription-based definitions, but accounting for visit cadence, which is usually going to be monthly, sometimes weekly, but monthly for patients. So I think this is something that we'll see how this plays out. I shared these results with NCQA, which had developed the initial 6-month measure that NQF endorsed. All right. But one of the other implications embedded in this is that if you're using a prescription-based definition, those are much more sensitive to the gap that's allowed. And so as you get to a 14 and a 7-day gap, the results really depart meaningfully from what you get with visit-based definitions, which I think suggests that the 7 and 14-day gaps aren't really clinically realistic for BUP. So this is the thornier part of the presentation around remission. This is work that's currently under review. So for those who are less familiar with the DSM, so the DSM has these 11 criteria for OUD, just like with any SUD. And if you meet 2 or 3, it's mild, 4 by moderate, 6 or more severe. There's, in the DSM, 90 days. If people go for 90 days without meeting diagnostic criteria, there's a term which is early remission. Now, the 90 days, 100 days shows up in other areas of addiction services. You think about AA, NA, you think about methadone programs, OTPs. You have to come in daily for the first 90 days, at least pre-COVID, pre-reforms. That was longstanding the case. And so, I think for us from different perspectives, plenty of us may think about 90 or 100 days as being a milestone in recovery. At the same time, this is a bit problematic because how do you capture this? If you look at EHR records, even free text, if you were to, whether you do it with manual coding or with natural language processing, you look at EHR records, they're not going to consistently or reliably tell you who's no longer meeting DSM criteria. There's an over-reliance on drug testing in the field, often for revenue generation, because people can bill for it, unfortunately. And then there are these financial incentives to drug test a lot. But in terms of person-centered care, I think we often are overusing drug testing in a way that doesn't support patient outcomes. At the same time, that is, a result that can be charted. And so we had a partner with this nationwide buprenorphine clinic system that required a drug test at every visit. So I'm not promoting the use of drug tests at every visit. But since we had those data, we wanted to see among patients entering care, if people did meet 90 days of continuous opioid abstinence, did that associate with their long-term retention? Which dovetails with this question of when the patient asks, when can I come off of the buprenorphine? That's a hard enough question to answer. That, the short answer is, stay on it. You're doing great, stay on it. For how long? Well, maybe forever. Patients don't like to hear that. It would also be nice to have a more exact answer, because there are some examples in medicine where we say something like that, but often we have more empirically informed ways to design our care algorithms in ways that have not translated so far to the care for OUD. So we looked at almost 20,000 patients entering buprenorphine treatment. We were able to link to the CDC NDI data for this to account for mortality. And what we wanted to do was look at people entering care, those who engaged. So they had 2 or more visits in the first month, which was virtually everyone who eventually could have been eligible for 6-month retention. And then among these people who stayed in care for at least 90 days, we looked at this outcome, which then became a predictor of whether people had 90 days continuous opioid abstinence. And if they did, compared to those who didn't, how did that associate with 12 and 24-month retention? So this is a bit of a busy table, so I'm breaking it up. So we're looking at the 6-month mark in care. Has someone achieved remission at any point in that first 6 months? If they did, we then looked at, were they still opioid negative at the 6-month mark? So this was more of the minority, but there were some people who had a 90-day period where they were consistently opioid negative, but then by 6 months, they had an opioid positive result again. Didn't happen too often. So it's sort of a 2-by-2 comparison here of, did people achieve, and if so, did they sustain opioid abstinence at the 6-month mark compared to people who didn't achieve abstinence or were intermittently using opioids, and how that associated with 12 and with 24-month retention. So if you look at this, and again, it's a bit busy, but if you compare the people who achieve remission and stay opioid negative at 6 months, 66% of them are still in care at 1 year, which is 4 times the rate or the percentage of people who are still in care if they don't achieve opioid abstinence. Part of what is surprising here is that people who achieved remission if they didn't continue it, basically you could sort of think about these two groups in the middle, which have equivalent outcomes, as being intermittent opioid users. I mean, that's my interpretation. I'm open to feedback on this. But what we're showing is that if in that first 6 months, people achieve 90 days continuous abstinence, and then they keep that in place, they have great outcomes compared to the people who are unable to achieve that. And this is actually more exaggerated for 24-month retention. So even 2 years later. Now, this syncs up, I think, in some ways with where, I see Modest on the call and Dr. Sarah on the call, that the early opioid positive urines or early, extinction of opioid use in care can be highly predictable. Roger had the study also showing this sort of, long tail or shadow of prognostication from that first month in terms of opioid results. This was meant to add to that literature, but also to try to tether it to the DSM in terms of the early remission term. So I'm going to try to piece all this together and then welcome conversation or questions. So we sort of think along the flow of the cascade. We're showing and trying to build out this empiric framework empiric evidence base under the cascade framework. The first month of care is critical. That buprenorphine treatment at entry has strong associations with care outcomes, such as opioid use, and that patterns of opioid use can wind up being highly predictive at the 6-month mark in terms of who's going to stay in care, even up for 2 years later, year and a half later. And yet, people who stay in care, even for a year, or at least what we've shown is even for 18 months continuously, when people drop out, it's really a high-risk event. So, final couple slides here in terms of tailoring care pathways, looking at the first month, so at treatment entry, and then again at the 6-month mark in care. Are there clinical decision support tools, or are there care pathways based on some sort of risk calculation that could be put into place at a system level? So this is a summary slide, wrapping everything up here. At intake, who we should worry about versus who we may need to worry less about. And then at 6 months in care, who we need to worry about. And the idea, just broadly speaking, that if we just sort of, if we're simple and think about high risk versus low risk patients at entry, and then at 6 months, who could have, for the low risk people, more streamlined care, really remove any obstacles, make it really easy for patients to stay in care versus the people who really need enhanced and more intensive services. I'm going to skip the case, and then go to this end, since we're getting toward the top of the hour. We think about at treatment entry, highlighting number one, who needs to be inducted on buprenorphine versus not. The window, if you think about it from the study I had shown, really predated fentanyl. It sort of overlapped when fentanyl was emerging, but I don't think it's at all as simple as complicated buprenorphine inductions. And I think we also know there are a lot of treatment settings that have really high rates of success with buprenorphine inductions, even among a population that's primarily using fentanyl. And then who's lower risk? So people coming in already on opioid negative. How can we tailor the care? So this is a sort of a short list based on what I would argue has the best evidence, but this is still, I think we need more research in those areas for interventions. And then at the 6-month mark, the most recent study I shared, looking at people who do achieve 90 days continuous abstinence and sustain that at 6 months, even if they came in with lots of baseline predictors of poor outcomes, some of those patients still achieve this 90-day continuous abstinence, and then they wind up having really good retention and care. But I don't think our care pathways necessarily reflect that. So it's the main emphasis of the talk, is to think about how to tailor care. So in summary, buprenorphine use at treatment entry really, I think should be at the forefront of how we think about who's at risk when they're coming into care. What are the interventions or wraparound services that could better stabilize these patients early in treatment? And then how do we or do we not in our care settings or in our health systems reflect the patient response to care, such as at the 6-month mark, to be able to shunt the patients who we maybe weren't worried enough about to get them onto the right track so that they may actually stay in care longer, more successfully. Lots of people over the years have contributed in many different ways to all of these studies. So I'll take down the slides and take questions, but happy to pull up any particular slide if people would like to go back to them.
Thanks, Dr. Williams. That was terrific. I want to open it up to the group for questions. If you want to type a question in a chat, I'm happy to read it. Or if you want to just sort of jump in, we can do that too.
Make a comment or just Jennifer, you want to say something? Go first.
Go for it.
So I mean, I was involved in the RDD trial and looking at the discontinuation questions. We made some assumptions about when we should start looking at this question, and we assumed that everyone should be on buprenorphine for a year and not using any opioids. So we sort of assumed some of the things that you assumed, just to allow people into the trial. So we won't necessarily get all the data, but you mentioned the idea that maybe you should be on this forever. I would play devil's advocate and say, well, if we take that approach and talk to patients that way, which a lot of people are doing, is that going to scare people off at the front end? And so we have to think about the psychology of this, besides just since we don't have clear evidence one way or the other, and we don't know if someone who's been on buprenorphine 10 years is going to be in danger. I mean, I don't think we can say that in any way. So curious what, I don't know, do you have any thoughts on that in terms of the psychology and how people will perceive it if you tell them, well, once you start on this, you really got to be on it for life?
Yeah, thanks, Modest. So I would one observation I would have from clinical practice is that when patients enter treatment, things typically are pretty bad and chaotic problems. Maybe there's an incident of whatever sort, and I think there's more because of that acuity. It's not usually in the intake when the patient presses, how long do I have to be on this? I think there are also plenty of patients who in their mind think it's methadones, liquid handcuffs, buprenorphines, this thing that they're going to be chained to for their whole life. And so they don't even come to treatment. But among the people who come who would consider buprenorphine, I can't think in the last 10 or 15 years of ever having at an intake a conversation about where I would say you need to be on this for life. And that's in part because there are plenty of patients who actually do really well and within 5 or 10 years taper off and seem to continue to do well, no longer taking it. So I think it is a non-trivial percentage of patients that could eventually taper it off and do well. And you can't know that at the outset. I think after people have been doing well, and I know some of you have also been involved in these studies where even within a month, but certainly 3, 6, 12 months, the patients, it's not really the external barriers to treatment access, it's the internal beliefs. They haven't used in 6 months. They don't want to keep going to appointments, paying the co-pays, just the logistics of it, the internalized stigma about being on a medication, all of these things. Lead patients to think that they're doing so well, they can quit the treatment, just kind of backwards. So I think it's really context dependent, but I think it takes some finesse. And this is where I like having 45 minutes with my patients because then you really get to hear them talk over the sessions. And then you know how to phrase these things in ways that won't scare them off from treatment. So, but Modest, I don't know if you had other thought or if other people have thoughts about that or the RDD.
No, thanks. That's good. I agree. I think, but I think you're right. I think it's the 3 to 6 months patients that are the ones that are impatient to get off buprenorphine that you're really sometimes very scared about, that maybe they're using marijuana, maybe they're using alcohol. Maybe, so things aren't that stable in their lives, but then they're already saying, well, I don't want to be on this forever. I don't like, so. It's,
I think we have time for one more question, sadly. Jennifer, did you have a question?
I did, though I hate to like overtake the folks who are in the chat. No.
Well, I'll just comment briefly. I think contingency management may have the most promise, but I think the problem is that even if you have a CM study, translating that to real world practice is so complicated. Fortunately, California had the first 1115 waiver to allow for a real CM pilot in the state. SAMHSA is saying the right things in terms of encouraging Medicaid to increase the dollar limit for that. I think we need a lot of research there, but that would be a go-to. I have another study I didn't talk about today where we had a intervention to try to help stabilize these high-risk patients early in treatment, and including higher dose bupe up to a target of 24 to 32. And the higher dose bupe may have helped a little bit, but not as much as we would hope. So I think CM is worth studying. And I think the SDOH is a bit of a mixed bag, actually, getting back to the point about if I had someone coming in who's unhoused and having all sorts of difficulties in life, but they're already taking bupe, I'd be less worried about them than someone who's stably housed, but not on bupe and using fentanyl. So I think it's very important, but only part of the picture. But Jennifer, go ahead. We'll try to fit in your.
So quickly, I think that whenever I see the information about people who like achieve abstinence early and that being a good predictor, of course, like clinically it makes sense to me. It also makes me wonder though, and I wonder if you have insight from your work or just thoughts about how you could study this, like how much of that is the program's response to that opioid use, actually making it uncomfortable for people to remain in treatment. I mean, we tighten things up, we put a lot more requirements on them, we make them feel bad about using opioids, and that like the programs could be creating some of that effect themselves.
Yeah, it's a great point. And of course, this is being recorded. For years, I worked with this community partner, and they assured me that they never kick patients out of care for drug use. And I thought, good, that's not going to confound our findings, that whole thing. And then, years and years you get into this, and well, we do have hundreds of clinicians, and there's some variability across providers, and everything's by protocol, but there's still, some of these, so it's inescapable. I think it's a great point. And we know that from methadone studies, the counselor can really make a big difference. Even in the same clinic, the patients can have a very different experience based on that relationship. So.
Robin, thank you so much. And you're right, this is being recorded. So people who that might be interested in it that were unable to attend, please share with them the link. I think it takes a little while before it's posted. And outstanding work. I'm assuming people that have further questions can contact you. I know you've been a generous colleague, for me at least, and really appreciate your work and your contributions to the field. So thank you. I wanted to turn it over to a couple of our work group leads. I know I don't think Dr. Hartzler or Dr. Glass are at the meeting this morning, but Camille, are you able to talk a little bit about the implementation strategies work group and maybe give an update? And then Sophia, it looks like you're here too, so maybe an update from the outcomes work group as well. But Camille, how about you get us started, and keep in mind the time for Sophia.
Yes, I will be very brief. So the implementation strategies working group is pretty much focused on conducting I actually need to know what kind of review. I think it's a scoping review right now, but apologies if I'm misleading folks. We are past the title and abstract screening process completely, which is really exciting to share, and in a full text review process currently, and then we'll be moving to data extraction. The purpose of the review is to not exactly identify evidence-based practices to reduce stigma in health settings, but to identify the strategies that were used when implementing stigma reduction trainings or other sort of interventions to decrease enacted stigma or the stigma that happens on an interpersonal level versus self-stigma within health systems. So really just trying to understand how do we just characterize what's going on and linking it to what works. But there's a lot of reviews right now that are looking at what works and what doesn't work, but not a lot looking at what strategies have been used. I think that's it. I think that there's still space to join our working group if you're interested in helping with full text review or when we get to the extraction phase. So feel free to reach out to me and I will drop my email in the chat.
That's great. What important work. It's hard work to do this kind of review. I know. Actually, I was thinking about Jennifer's question about, program philosophy, which, does bring up an issue around stigma, I think, in terms of use of medications and let's say even low barrier type care. So really, really interesting. And we definitely need more knowledge on what works there. Sophia, are you still on?
Yes, I'm here.
Maybe an update on the outcomes work group.
Yeah, of course. So our work group is currently working on a review of implementation outcomes included in CTN protocols. We have finished data extraction and consensus and are actively meeting to go over our results. And we're working on summarizing them and preparing a manuscript, which will hopefully be ready by the end of the summer. And that's all for us. Thank you.
That's awesome. Are you still open to new group members, or would you say that you're well on your way?
I'll let Dr. McNeely answer for if we're open to new members.
Thank you. I think my sense is that the review itself is much of the work is done for the review, but we welcome new.
And press space to toggle an option.
Uh-oh, the computer is cutting me off. So I think that folks are welcome to join the group and see what we're doing. I think that the systematic review, the work is mostly done, but we are a welcoming group and welcome folks who are interested. So I'll put my email in the chat if anybody wants to be linked to our group. We'll send you the schedule of meetings.
That's great. Good. And I see Camille has already done that. Well, awesome that the work groups have actually developed work. Sometimes work groups can kind of meet perpetually without an endpoint, and it looks like both work groups have achieved their goals. So that's really awesome. And there may still be more to do with both of these work groups. I wanted to also let everyone know that we are going to meet in July. I know some folks have a lighter schedule in the summer, but this group will continue to meet every other month, and July is the next meeting, July 16th. To be specific, noon Eastern, 9 a.m. Pacific, and we're excited to have a colleague and friend, Dr. Matthew Alsma, who's at the University of Indiana. And I'm not sure exactly what of his extensive portfolio Matt will be presenting on. It could be the work he does with justice-involved patients, or it could be work he's doing across the state of Indiana with opioid overdose response teams at the county level. So I don't think we've got a commitment from Matt as to which of his numerous projects he'll be presenting on. He also is doing work with adolescents, which we tend not to hear as much about when we think about substance use disorders and in particular opioid use disorders. So we will know more about the topic as the date approaches. But in the meantime, really thanks everyone for joining us. Robin, if you're still on, thank you again for your great work and for sharing it so generously with all of us. And really appreciate everyone. Thank you and enjoy the rest of your day.